This is SiriusXM Doctor Radio.
Direct from the NYU Langone Medical Center, here is vascular surgeon Dr. Todd Berland.
Hello, Dr. Todd Berland here, vascular surgeon, broadcasting out of NYU Langone Medical Center. It's a beautiful day, and we are listening and talking on the Vascular Surgery Show. SiriusXM Channel 110, 1877 NYU Docs. That's 1-877-698-3627. We're talking vascular. We've got a 2-hour show ahead of us here. Before we get into the actual first segment, I just want to kind of set the lineup here. We've got Dr. Felucio Faccareti from Central Mississippi, who's a cardiologist. We'll be talking about some of the disparities in medicine and about vascular and endovascular surgery in general. We'll then be moving to a podiatry section where we'll talk about the foot, some of the cosmetic natures with Dr. John Brummer. We'll then be talking about vaccines. I love to have the vaccine segment on the show. It seems to be so important. Family members, friends, everybody seems to be talking vaccine, so we'll be getting an update from Dr. Jason Newland in regards to the vaccine. And the last 30 minutes, kind of open questions, all things vascular, whether it's aneurysms, varicose veins, blood clots, venous insufficiency, peripheral vascular disease, you name it, you can call in. That last 30 minutes, open segment there, 1-877-698-3627. But let's move on to our first segment, and I want to introduce our guest, Dr. Felucio Faccareti. Dr. Faccareti, thank you for joining us.
Good morning, Todd. Thank you for having me. How are you guys doing?
Yeah, great. Thank you for joining us. I really, I heard your story over the past several days or week, and certainly very interesting. Listen, let's hear about your background. I understand that you were born in Nigeria, you trained in New Jersey, and now you're in Central Mississippi.
Actually, yes. Born in Nigeria, I came to the States at a young teenage age, lived in North Jersey, did all my schooling at Rutgers University and Robert Johnson Medical School. And right after medical school, I attended New York Presbyterian Hospital Weill Cornell for internal medicine residency. So I was your neighbor. And went back to New Jersey for both my cardiology and endovascular fellowships. And that's where I really got a keen interest for peripheral arterial disease, which was actually my weak point coming into fellowship. I was not big on PAD at all. I was just wanted to be that interventional budding cardiologist. But after looking at the spectrum and at the regional variability of delivery of care, not only in the heart space, but if you look at just overall health burden of Americans, and you look at how disproportionately affected communities of colors are, that was something that I leaned in on while I was at Rutgers University with the Office of Diversity and Academic Successes in Sciences leading the way, and subsequently looking at the regional variability and delivery of care, showing amputation rates being highest in the Black census scope of America with the lowest revascularization rates. It was an opportunity for me to kind of, delve into why I needed to target these communities, how we could address their health inequities and social determinants of health, provide compassionate care, and try and shift that downtrend in cardiovascular mortality into an uptrend where it could be a healthy oasis for these underserved people who lack the voice in the struggle of downward generational mobility.
Yeah, listen, very well put here. Certainly, Central Mississippi is different than North Jersey, so certainly a different environment there. I grew up down south as well, from Atlanta, and my wife is from South Carolina, so I'm very, familiar with kind of the southern roots there. We've all known in medicine the huge disparities between African Americans, Latinos. With the white population. What part of this do you think has to do with the socioeconomic versus the fact that we know that, just say African American population, higher rate of diabetes, higher rate of hypertension? Right. What plays into it just from a genetic standpoint versus the socioeconomic?
Well, that's a great question, Todd, because, one thing that I've realized is that, when you look at the causes of disparities and look at the profiles, while genetics and this gene-environment interaction are important, at the core of disparities, we should not assume to be caused by genetic differences. Race and ethnicity in these settings should be viewed as kind of social, not biological constructs. So other key determinants of disparities, which are predominantly 80% of the causes of health disparities in this country, are things such as not only access to care, but access to quality care that's delivered, the systems of care that are in place, the geographic and environmental influences, the income and educational levels and how, underrepresented they are in communities of color. Prejudice and discrimination plays a role. Provider biases, psychosocial stressors, personal beliefs, and lifestyle choices. But here, what I found, like here in Mississippi, which is at the heart of the diabetes belt, for instance, for decades, even though we've seen a reduction in cardiovascular mortality nationally, Mississippi has had no significant change in that trend, with certain counties actually lacking provider coverage. Out of the 15 states in the diabetes belt, Mississippi is the only state where all counties are represented. However, only less than 10 endocrinologists exist in the whole state.
Yeah.
Right? And for you and I that train in New York, those differences are shocking, because between NYU and Cornell, we could get more than 10 endocrinologists.
Yeah, well, we've got 20 right on the block here. Yeah.
Right.
Yeah.
So as a Black interventional cardiologist with an excellent training to save limbs and to save hearts, you delve into, well, what can I do to go to a state that has the highest percentage of Black population in the country, which is Mississippi, with 40% Black population, in the heart of the epicenter of cardiovascular disease, and what can I do to try and address those social determinants? And that's why I focused on PAD, and more than happy to talk more about that as well.
Yeah, listen, that's my favorite part of the vascular, kind of my vascular specialty as well. I'm a big fan of PAD, or peripheral arterial disease. Kind of just taking a step back for the listeners just joining us. This is the Vascular Surgery Show. You're listening to Dr. Felucio Facorede, interventional cardiologist out of Central Mississippi. I'm a vascular surgeon here out of New York. Both of us doing a lot of overlapping procedures treating peripheral vascular disease or peripheral arterial disease. If you or a loved one have had any interventions, or maybe you've told that you need a procedure, or maybe you're told you need an amputation, or you've had one and are willing to share your story, give us a call, 1-877-NYU-DOCS. That's 1-877-698-3627. You can also email the questions, docs@SiriusXM.com. So, Felucio, let's take a step back here just for a second. As an you're an interventional cardiologist, I'm a vascular surgeon. For decades, we've kind of accused you guys, you interventional cardiologists, of being lesion-oriented. Now, just kind of work with me here. You guys have trained in the heart, kind of historically. Now I think the modern-day interventional cardiologist does have PAD training, but historically it was your training migrated from the heart. The skills that you guys had to manipulate and get into the coronary vessels, those small vessels, in a moving target, the heart's always beating, where we could have the leg still during an intervention. So those skills translated well from the heart to the leg. You guys were good at that. But we felt that you guys were so lesion oriented. If you saw a blockage, you wanted to open it up. So in the coronary arteries, that may have mattered more. You have a clogged artery, you want to open it up. Where we argue in the leg, not every blockage needs to be opened up, and not every blockage is about to cause an amputation. What are your thoughts on that?
That's a great question. And for decades as well, we in the interventional cardiology space have felt that the underpinning of all cardiovascular diseases and the shared risk factors all lead to one common pathway, which you and I know is atherosclerosis, right? And for your lame audience, it's the buildup of cholesterol and fatty substances that cause the narrowing of the blood vessels and decreased oxygen flow to the vessels. And that lesion specificity that you define comes with a percentage in the heart versus the peripheral arterial tree, and we determine what is worth treating versus what is worth intervening on in terms of treating medically versus interventionally, right? But from my lens, what I think, has transpired is that the benefit of having an interventional cardiologist on your team, on the multidisciplinary team, which we'll talk about later, is that the short-term outcomes of peripheral arterial disease are as follows. Patients die of heart events. Patients have strokes. Patients have, other consequences that an intervention in itself is not the solution. The prevention of the progression of plaque buildup is what we thought we needed to address. So the field entails an ability to upstream treat those who we consider at risk and downstream intervene on the space. Now, vascular surgeons have predominantly dominated this space. And it's a fragmented space because now we have interventional radiologists as well. However, the mindset in which there's a market share kind of tug of war, I think we focus more on the end stage and the interventional part, and we actually put less of an emphasis on how to prevent that cancer from going from stage 1 to stage 4. And that's why I'm proud to be on the spectrum as an interventional cardiologist, addressing that upstream battle.
Right. I think we all can really agree that it's a systemic problem when you're talking about atherosclerosis. And you might have a clogged artery in the leg, but if you've got that, you've got clogged arteries elsewhere, and it's a marker. And sometimes patients come in thinking that that's their only issue. And you're right. Once you identify that, it's a heart attack or stroke they're most likely to die from. So we've really got to change that. Quick kind of specific question for you. The COMPASS trial, low-dose Xarelto, the 2.5 milligram, the vascular dose that they're talking about here. I was recently doing a webinar last week talking with other interventionalists, particularly Europeans, who seem to be very keen on adding this low-dose 2.5 milligram, right? We're talking the medication for the listeners. I know you know this. The same medication we treat to thin the blood for blood clots or patients that have atrial fibrillation, we're giving at a quarter of a dose, really an eighth of the dose, but twice a day, to really kind of thin the blood just a little bit in patients like this, in hopes to maybe make our interventions last longer, but really in hopes to make patients live longer, because we've seen a huge reduction in cardiovascular death, stroke, heart attack in patients who take this low-dose Xarelto. What do you think? Have you added this into your regimen? And when you treat patients, talking about your whole kind of treating the upstream effects and trying to prevent death and stroke, are you adding this medication now in 2021?
Well, you know what? It's a great drug. However, I have some issues that regarding how the demographics of the trial was actually and the content, all right, and that's part of this whole disparity spectrum. The COMPASS trial was very well done in terms of the design of the trial. However, the demographics that was represented, you look at almost 27 to 28,000 patients. They could only find about 250 African and Black patients for that whole trial. Right. Mm-hmm. And so as an interventional cardiologist here in the heart of the Mississippi Delta, taking care 80% of my population are Black. And so when a representative from the company comes to my office and quotes all the mortality benefit data, right? Todd, the first question I ask is, how does this apply to the real world population that I treat here in the Delta? Looking at the demographic that trial encompass. So
I hear what you're saying. But the counterpoint is most of the trials have this disparity. This is a huge issue in medicine that we're trying to address right now. All the trials have this disparity.
I know. It is, but you also know that these disparities lead to policies that sometimes actually disproportionately affect patients of color in treatment and in outcomes. And so if you cannot document that, right, you don't see it. But that's an aside. I think overall it's a great drug, but the two big things that we need to address is how does it apply to all other populations? And we need to do subsequent studies on that, and I think people are working on that. And two, the cost is an issue, especially in a place like Mississippi where patients have to think twice about the cost of a medication given their social determinants. And the cost of a drug that costs $200 to $300 a month plays a big role if your median income is about $36,000 to $40,000 a year. So that's part of the things that I have to think about when I prescribe the drug. But it is a great drug if you look at the outcomes and mortality benefit, as in any drug that comes through your office store, right? Once you mention mortality benefit, you have the attention of the provider, because you want your patients to live longer and to have good outcomes when it comes to major adverse limb events that were prevented. So that's something that I have to think about when I'm taking care of my patients who have, all these comorbid issues.
Yeah, certainly very interesting. Again, for those just joining us, we are talking about peripheral vascular disease or peripheral arterial disease. We could certainly get into some of the specifics of interventions. I'd love to chat about that. We've got Dr. Felucio Facorede out of Central Mississippi, interventional cardiologist. I'm Dr. Todd Berland, vascular surgeon here out of New York. Give us a call, 1-877-NYU-DOCS. That's 1-877-698-3627. You can also email those questions, docs@SiriusXM.com. All questions regarding PAD. So, Felucio, treatment. I guess I should take a step back and say, would you treat patients differently based on their ethnicity, based on what you know from any available data in trials? I'm not talking about socioeconomic or anything like that, but just maybe on seeing how Latino patients versus African American versus white patients would respond to different therapies. You mentioned the Compass trial disproportionately had a white population. That was done OUS. There was a lot of OUS centers in that one.
Correct.
When it comes to treatments, do those vary? I personally, I don't know that I have ever treated differently or appreciated anything different.
No. When you're limited with what you have, I mean, you can't take that out of the box in terms of your options, right? So if you look at your toolbox and if you look at your treatment box and what you have in those boxes or what you have, so antiplatelet therapies we know are important in this space. Statins are important in this space. ACE and ARBs are important in this space. All these drugs have had underrepresented patients. However, we still utilize these drugs because our patients actually do well. It's just, it's just the fact of, what we see when it comes to upstream cardioprotective mechanisms and treatment options that are available for these patients. So I think that, when you look at the most prevalent, morbid, deadly, and most expensive chronic disease that most Americans have never heard of in PAD, that disproportionately affects, a community of color such as African American 3x compared to a non-Hispanic white patient, and who all carry those risk factors that you and I know, diabetes and high blood pressure and high cholesterol. Those medications to treat those conditions, we cannot use a race-specific treatment algorithm in the context that the only mortality benefit drugs that are available are, disproportionately ones that excluded those populations. So we can't. There's no other option for me to use or utilize when it comes to treatment of these patients. Mm-hmm. So you just have to use them.
Right. Let's talk about the actual treatments. I was recently involved with a roundtable, kind of a Zoom roundtable, because that's how everything is these days. I believe you're a believer in atherectomy. I know I use it. I think that you do as well, from what I could see and find out about you. Am I wrong? Do you use a lot of atherectomy in your practice? And for the listeners out there, what I'm talking about, in addition to stenting or balloon angioplasty, where you go in and open up the blood vessel, atherectomy is a process where you can kind of change the compliance of the vessel wall with a device that kind of removes plaque or changes the form of the plaque, whether it's actually cutting it out or shaving it down or lasering through it. Do you use this in your practice?
Yes, you do. Yes, I do. Because, when you talk about patients who have calcified vessels, especially patients who are either nicotine users, patients who have chronic kidney disease, for which African Americans are 2 to 3x fold higher, patients who are diabetics, and patients have below the knee disease as well, where that calcified tree is hard to treat with just plain old ballooning in terms of their poor outcomes without vessel prep. That's something that you have to have in your toolbox and available in every lab in America today.
Yeah, I agree with you there. Not everybody agrees with that, but I do agree with you, and we do use multiple types of atherectomy.
Right. So there are different types. You're absolutely right. There are different types, and societies are now trying to come up as we should. And I know SDS has worked on this, and Society of Coronary Angiography and Intervention Sky is working on this as well, in terms of what the standards of care should be for patients who have chronic limb-threatening ischemia. Right, the name keeps on evolving. We went from PAD to then just focusing on CLI, chronic critical limb ischemia, now CLTI, and ultimately it's identifying the right patient with the right treatment and making sure that we still undergo patient-centered focus. And you share the options with these patients ahead of time, so they have an informed kind of consent in terms of the decision-making tree, which is how we practice down here.
Mm-hmm. Certainly very interesting. We don't have a ton of time, but kind of where should we be moving as a medical profession in the future? How can we better address these disparities? You're down there living it. What does a guy up here in New York do?
Well, first of all, a guy up in New York has to realize that there's a large opportunity to come to an underserved community, especially those communities where you can look at the burden of health, and predominantly these communities are in not only the southern states, but also in states where they're at the bottom of the totem pole when it comes to social determinants of health. You can move to those communities and try and raise awareness within the community as to why we are suffering the bad outcomes that we see when it comes to cardiovascular health. 2, you can engage the providers in that community and educate them about conditions such as peripheral arterial disease and why it's so prevalent and why it's so under-recognized and undertreated. Things as simple as taking off the socks of patients are things that are not practiced in a lot of practices today, and looking at patients and inspecting their feet and inspecting their pulses. And making sure that when you look at the guidelines and the treatment systemically, engage in societies so that we can question why the underrepresentation of these patients in clinical trials, for instance, has led the organizations like the U.S. Preventive Service Task Force not to endorse screening at-risk patients, majority of whom are minorities or at the low socioeconomic levels. And so you as a physician who has great training can come and actually affect change by being that voice for them to crack the stagnation in the topic that has spanned decades. And that's what a place like Mississippi has done for me in terms of my, setting up a legacy in trying to decrease the amputation rates, which we've successfully done by 88% over the last 4 to 5 years.
Excellent. I mean, that's an interesting number here. We've treated lots of patients. I feel like it's such a hard number to look at, and you're able to quote 88%. We've done lots and lots of procedures over a long period of time, and the question is, how do you get that number? How do you know? Because we like, again, back to that lesion specific. We see patients. We understand that claudicants, people that have peripheral arterial disease, who don't have tissue loss, they don't have an opening on their skin, they don't have an ulcer, they might just have some pain in their leg, and you can't feel their pulses. We all know that their risk of tissue loss is about 1% per year. So 99% of those patients don't, at the end of a year, don't lose any tissue or a toe or their foot.
Right.
So how do you follow this? Because it's so hard to study.
It's hard to do, but you also you reside in a system where you have the availability of all multidisciplinaries to you, right? So I don't know how many podiatrists you have in NYU and how many infectious disease specialists, and vascular surgeons, and interventional cardiologists and radiologists. But when you go to the rural areas and you go into hospital systems and you look at the amputation rates in a lot of these hospitals, what you see is trouble, and what you see is despair. Because trouble in terms of how high these amputation rates and how there has been a mistrust in the healthcare system that has spent decades, where patients who are diabetics, for instance, in the state of Mississippi, who are not, one, being screened, and two, who show up to the emergency rooms and to the hospitals and where an amputation first strategy is being employed.
Mm-hmm.
And when you can have a physician with a skill set, so if I were to take Todd and bring him down here to a rural hospital and park you here for 5 years and show that, you know what, the hospital is performing almost 50 to 100 amputations a year, and you can get that down to about 7 or 5 a year by screening these patients, by making sure they have ultrasounds done, by implementing optimal medical therapy upstream. For those who have, CLTI or who are claudicants and who have failed, supervised exercise therapies and optimal medical therapy and need an intervention, or who have tissue loss, mm-hmm. You do an angiogram and you look at their arterial circulatory flow and you determine if they need an intervention or not. And most of these patients are not offered either optimal medical therapy, nor are they offered an angiogram before an intervention.
Right.
And that's how you see those numbers drastically come down, because that disparity does not exist in terms of presentation at such a severe state, as you and I know that diabetics show in places like in New York versus a place like the heart of the diabetes belt here in Mississippi.
Right. Well, I think you hit the nail on the head. If you've got an area that kind of has one major hospital, and you could see how many amputations that hospital did in 1 year and track that and see that it's decreased, that's kind of your objective evidence. I think we don't have our patients kind of bounce around. They go to different hospitals. There's a hospital every 9 blocks. So it's hard to really know how many amputations are being done, because those patients may not show up to you if they have gangrene, or they come in the middle of the night with fevers and they go to a different hospital. You just don't capture that data like you would in an area where it's more of a centralized kind of hospital system. So,
and who are the doctors doing the amputations? You have to realize that most of these doctors are not vascular trained, and most of these patients have access to maybe general surgeons who just are not well familiar with even the pathophysiology of how this disease works and what the treatment options should be in 2021. I mean, it's barbaric to think that an amputation first strategy should be employed as a treatment for CLI or CLTI in 2021. It's barbaric. You agree with that, right?
100%.
And so our work has led to multiple stakeholders, and shout out to bipartisan effort by congressional staffers to see how we can educate not only Congress and communities about PAD while supporting activities to improve PAD education and reduce non-traumatic amputations. And Congressman Payne Jr. and Gus Bilirakis of Florida have led this bipartisan effort that has led to the establishment of the PAD Caucus and introduction of an Amputation Reduction and Compassion Act. So I encourage a message to your audience today that we need to not, one, speak more about PAD as you do every weekly, Todd. Two, we need to engage all stakeholders to help raise awareness. The oncological field got it right. You know what they did together? They came together and they helped put one concerted effort to inform the whole entire world that we have a problem with cancer. We have failed to do that with PAD. Your patients and your audience members, only 1 in 4 have heard the term PAD, right? Patients just don't even know what that term means in the community. And so we have this platform, and that's why, I thank you again for having me on, but we have this platform where we need to speak more about it, not on Heart Health Month, not on PAD Awareness Month, but every month.
Right.
We're still catching up. We have a lot of work to do.
I agree. Listen, very, very well put. And, the time has kind of flown by. Certainly would love to have you on again and get your perspectives on lots of different things. So certainly been very interesting, and really want to thank you.
Thank you very much, Zach. Appreciate it.
For the listeners out there, Dr. Felucio Facorede, interventional cardiologist out of Central Mississippi. We've just been talking about peripheral vascular disease and peripheral arterial disease, PAD, really important, underserved, underappreciated topic. We can all agree on that. And Felucio, really thanks again for joining us. We're going to have you on again. For the